I just discovered this video on Vimeo. Judith GOULD talking about how the autism spectrum came to be. Very interesting story.
I'm the director of the Lorna Wing Centre, and our main function has been diagnosis and assessment. We started 20 years ago. At that time, it was very difficult to get a diagnosis, and so when Dr. Lorna Wing and I set the place up, we went to the National Autistic Society and suggested perhaps they wished to work with us and support this idea. So that's how it all began. And so essentially we were diagnosing young children who were not being picked up at a local level, often very obvious children that we thought, well, you know, why were they having to travel great distances to Bromley from all over the country for a diagnosis? So that then led us on to saying, setting up our professional training for diagnosticians so that children would be seen at their own local level rather than having to travel. And our two main roles, functions, are diagnosis, assessment of needs, and training of professionals. When I started as a student in clinical psychology at the Maudsley Hospital, there were children who I became involved with. And I can remember vividly there were two particular children. One was a little girl who was very challenging and a very unhappy child and was self-injuring and pulling her hair. And she was quite difficult to work with. And then there was a little boy who was an absolutely beautiful child. And at that time, we were very much into what we call applied behavioural analysis, ABA, and the Lovaas approach. And I can remember getting him to look at me by popping Smarties into his mouth. And so those were my first experiences of autism, which is very unlike now. And leading from that, I then was very fortunate to become a research assistant with Dr. Lorna Wing at the MRC Social Psychiatry Unit. We were involved in a very large epidemiological study in Camberwell in South London. And Lorna was interested in autism, and the idea was we were going to look at every child who was living in the borough, was born on a particular day, and look at their pattern of skills and problems. The idea being that we were interested in looking for Kanner's classic autism. Leo Kanner wrote in 1943 about a group of children he was seeing in his clinic in the States. And they were described as socially aloof. They had elaborate routines. They were pretty cut off from contact with people. If they did communicate, it was usually for their needs or maybe physical contact, but it wasn't for the purpose of social communication. They often had high levels of skill, but these were what we called islets of ability. So they may be very good at puzzles or putting things together, but they were not good at playing in an imaginative way. But what we were finding was there were children who had resembled the Kanner's group, but also had different patterns of social difficulties and communication difficulties. And so from that early work came the concept of an autism spectrum. So we were describing a group of Kanner's autism, but there were far more children who had aspects of behaviour that were similar but not fitting into those precise criteria. So from that work came the idea of a triad of impairments. And those were difficulties in social interaction, communication, imagination, and if a child had those three areas of difficulty, it was strongly associated with a repetitive pattern of behaviour. I think our view here has always been that they do have a use, particularly for clinicians who are newly qualified. All of us like rules and we like to have definitions of behaviour patterns, but unfortunately, with a behaviour pattern such as autism, people don't fit nicely and neatly into categories and boxes. So by setting out definitions, they really have to be defined quite clearly. Whereas in the systems, they're quite vague in their description of if you've got a social interaction problem, what is social reciprocity, what do we mean by communicating in a social sense. So the classification systems attempt to formalize, operationally define what we mean by autism, but actually people interpret these in very different ways. So as the systems are at the moment, there are big difficulties, and currently they are revising both the International Classifications of Disorders and the American DSM system of classification. The Triad of impairments from our work in Camberwell, as were rather then, when our thinking in the 70s, the children had problems in their social interaction, their communication and imagination. Now, that's what the triad of impairments are. And if you had that pattern of those three areas of difficulty, that was strongly associated with a repetitive pattern and resistive pattern of behaviour. So the triad is that, not the repetitive patterns of behaviour. In fact, recently, one of our colleagues said, well, why did you call it the triad rather than the quadrad? There are four. So we speculate that having the three areas of difficulty is an association with repetitive patterns rather than it being the autism. Now, what is going to be happening in the future is that's going to change, but that's maybe something for the future. The questions we were asking in our study was very much research-based, so we needed an instrument that was going to be more clinically useful, taking into account the autism spectrum as opposed to the more narrow definition of autism. So what emerged over time was our diagnostic interview, which is called the Diagnostic Interview for Social and Communication Disorders, with the acronym DISCO. It had to evolve into a more clinical instrument so that we can diagnose people of all ages, all manifestations of the spectrum, and all levels of ability. So our diagnostic methods have evolved over time using our specific instrument. Lorna Wing and I had consultant positions within the Maudsley, and so we were doing clinical work as well as our research. And we were being referred adults who the team within the psychiatric division were unsure about the diagnosis, and Lorna made connections that there was an overlap with some of these individuals who were not diagnosed with schizophrenia or other of the psychiatric conditions. And she actually had read Asperger's work. He was only writing in German, and Lorna's husband John spoke German. So he translated Asperger's paper, the 1944 paper, and Lorna made that connection of the overlap. So in 1981, she wrote her definitive paper referring to Asperger syndrome. So in fact, she coined the term Asperger syndrome, because in German, it was referred to as autistic psychopathy. And interpreting of psychopathy in English had a different meaning, so she referred to it as Asperger's syndrome. And the point of that was that the individuals who were presenting like Asperger's description were no way like the Kanner's autism I've described, but we could see the links between the two descriptions. And understandably, somebody with Asperger's syndrome would not identify with somebody with autism with a learning disability. So at that time, it was a very useful definition and a useful term, but it was in 1994 that it was included in the DSM and ICD classification systems. The reason why it's difficult to diagnose adults as opposed to children is that the diagnostic systems that we use are recognising that autism is a childhood condition, a neurodevelopmental disorder, and so all our questions relate to early childhood development. Now, it's very different when you're seeing an adult for the first time. It may be that you haven't got informants to give you a developmental history, or the person themselves do not wish to have their parents involved. So that makes the diagnosis more difficult than for a child. We've adapted the DISCO to take into account adult presentations of behaviour, and we can diagnose with the DISCO adults. What we can't do is, if we haven't got an early history, correctly, we can't use the ICD and DSM classification systems, because as they stand at the moment, there is this arbitrary cut-off that if you have a problem before you're 3, you have autism. If you don't, and your difficulties occur after 3, you are called Asperger syndrome. Now, in reality, children grow up to become adults, and they shift their diagnosis from Kanner's autism into Asperger syndrome. So adult diagnosis is certainly more difficult, but it can be done if you ask the right questions. There is an increase in diagnosis over recent years, and I think the reason is that people are far better informed about autism. And I have to say that has really been part of the National Autistic Society's mission. Raising awareness amongst professionals has been terribly important. And I think that the training that we've offered here, and not just we've offered, other people offer training in diagnosis, that really has made a big difference in people's understanding that this is a condition that does need a proper diagnosis and a good assessment of needs. We were getting a number of women and girls who were referred who are not being picked up at a local level, which sparked our interest. And then we realised, of course, that their manifestation of the condition is different from the male presentation. Kanner recognised girls, but Asperger only was seeing boys in his clinic way back in the 40s. So girls have always been around, but the girls who are diagnosed are usually the more obvious and often with more learning disability. So the brighter females were not being picked up as having autism. Overall, they are more social, and they mask their problems far better than the boys. They are often very passive in their presentation, and because they are not a challenge in school, they're not presenting with behaviour difficulties, they just somehow merge into the background. DSM-5 is the latest version of the American classification system. What they're planning is to merge the social and the communication problems into one category. So moving from social and communication being separate and repetitive behaviours being separate, social and communication disorders are going to be into one, and repetitive behaviours into a second. So that will mean that the definitions will change. All those individual labels they're planning to remove. We don't agree with removing these descriptions of the different individuals. So the Asperger description should remain, but as a description rather than a category, whether you fit or whether you don't fit. Now, what we do here, when we give a diagnostic formulation, we refer to someone as having an autism spectrum disorder or condition, and then we'll say, and this person best fits that description of Asperger. And in reality, what we care about is how we can help a person, not what the label is. So removal of labels, I think, could be useful. In the attempt to recognise dimensions, so that just saying autism spectrum disorder alone is not going to be very helpful, they have proposed severity levels. It says needing very substantial support needing reasonable support or needing very little support, something like that, and without again any definitions of what that means. And a kind of linking that if you have severity in social and communication, equally you'll have severity in your repetitive patterns of behaviour, which isn't the case. Nothing fits neatly into these categories. So we definitely need to understand severity, but it has to be done in the light of assessment of needs. When we make our diagnosis here, we actually have assessed the individual in terms of their skills, their difficulties, their level of ability, visual spatial skills. So we have a very definite, clear picture of one individual. In our changing view of the triad, we now refer to social interaction, social communication, and social imagination. Particularly the girls and women learn the rules, the social rules, but it's an effort which can often leave them very exhausted. So our triad, the link in the triad is the social interaction. But if somebody is presenting with difficulties in their life, in their work, in their relationships, in the way people are treating them, and they need to know and understand why they're different, then the diagnosis of Asperger syndrome is very appropriate, and it will have implications for resources. And in terms of identity, if you are given a description of your behaviour and then some committee is deciding that you don't have it anymore, of course it's your loss of identity. The people with this description do see themselves as different from somebody with classic autism, and they are different. In the drive to remove labels and remove descriptive categories, they have now created a new diagnostic label called social and communication disorder. And to fit into that category, the person has to have a social and a communication problem without repetitive routines. Often people do have repetitive behaviours and routines that are less obvious than the ones with the more typical autism. The women's special interests may be celebrities. Their more social interests. Their repetitive interests and routines are very different from the male stereotype of objects, trains, transport. So if a person doesn't understand the whole of the spectrum and the different manifestations of behaviour, there is going to be a new group of people classified as having a social and communication disorder, but not autism. And so what sort of support and help they're going to need, I would like to know. The schedule is for DSM-5 is March 2013. I don't know about ICD-11. If it's the same as last time, DSM-4 came out and then ICD-10 followed. So I suspect that it will follow in the same path. Now, what will be the implications for us here is that we've looked at the new criteria and we see that it overlaps with what we work on currently. And what we're doing at the moment is we're looking at our DISCO, and we have a team of researchers at Cardiff University who are now looking at the DSM-5 descriptions and looking at the questions in the DISCO that relate to those descriptors of behaviour. So we are going to be up to scratch when DSM-5 comes out, so that we will have consistent diagnosis using the new systems, and hopefully that will be the same for ICD-11. The inclusion of hyper and hyposensitivity is a very important aspect of the new DSM-5, because if you're in an environment that's overwhelming in the sensory sense, that's going to affect your ability to communicate, to interact socially, and to be yourself. So it has major implications on your management. So we are very pleased that it is now included, but also that you don't have to have it. You know, it's there as 2 out of the 4 of the criteria. The reason I feel that diagnosis is so important is that it's the pathway for somebody's life. You have to have a starting point. You have to have an understanding of why a person's presenting with difficulties. And without that understanding and that ability to help and support that person, to my mind, can only be positive. The whole concept of labelling, where we went through a phase where people said this is just a label and we shouldn't be labelling people. I really don't think that's a viable argument. I really think that if somebody is presenting with difficulties, then they should be addressed. I don't see it as negative, and I think that the people we see and we diagnose often say how relieved they are to have some understanding of why they've struggled through their lives.
Exactly.
In my experience, professionals fall into 2 groups. Those who are open-minded and are prepared to say, I've got it wrong, and are prepared to listen. And unfortunately, there are also professionals who are very dogmatic and rather rigid, and it's very unfortunate then if somebody is referred to a person who isn't open-minded. And when it comes to children who are more complex, we've always said, listen to the parents. They know their child far better than we do as professionals. And if their story is telling you from early on that their child has had problems throughout their life in their social communication, social interaction, then just listen and not dismiss them as being over anxious, neurotic, etc. I think that the training generally, the NAS offers training, we offer diagnostic training, that hopefully will help professionals to see the subtleties. If we're seeing somebody here for diagnosis who's very able, very articulate and has lots of insight, then it may be preferable to use the term autism spectrum condition. Whereas if we're seeing somebody who has learning disabilities and is in need of a great deal more support in terms of being resource-led, then the term disorder may more likely get the services they need. So whether you use condition or disorder, I've looked it up in the dictionary, and I guess disorder has a more medical implication. But if we want resources for our individuals, we need to have to say there's a problem rather than it's a different way of being.
Yep, I understand that.
The autism strategy and the pathways are really important, and having the autism bill through the NAS has really made a huge difference for adults. Before, there was no legislation and nobody needed to do anything, whereas for children there has been legislation, so services have been better. So having the autism bill has made a difference, and then having the autism diagnostic pathways. It is still very, very patchy. There is some really good practice, and people are really getting to terms with this and setting up diagnostic groups. And interestingly, I think that's why we're having more people applying for our diagnostic training from adult mental health and forensic services than we ever have had before. I still feel that diagnosis has to be multi-agency rather than a single individual. So bringing together different professions from different perspectives and looking at the whole is vital for the diagnosis. It is easier to observe children in different settings, in school, playground, etc. But observing adults in different settings can happen, but it's not so easy. For me, having now met people in the wider spectrum, their insight is really what has made the difference. Because how do you know what's going on in somebody's head? But for people with the condition who are able to explain to us professionals what it's like to have this condition really has changed our thinking. And many of the biographies, autobiographies written by people themselves has really given us the clues to what autism might be.
There's another one with Judith GOULD, Autism in Women and Girls.
Well, it started with a conference in around about 2008, when it was thought that we really ought to address the problem that women and girls might be different, and diagnosis was difficult for them. So that started the interest, and then as a result of that, at the Lorna Wing Centre, we started getting referrals for women and girls in mental health services. And it needed teasing out because many of them were misdiagnosed with mental health problems. Some of them did have mental health problems, but the underlying cause was that of autism, and that had been missed. So that started the interest. But I guess really from even further way back, when we did our Camberwell study many, many years ago, the girls presenting were functioning at a lower intellectual level, and they were easy to pick up because their autism was more like Hannah's autism rather than the Asperger presentation. So I've always been interested, but it really became more evident in the last few years, and now we're seeing young girls whose mothers have a diagnosis of Asperger syndrome, and where they not wanting their children to have gone through the difficulties they've experienced with a very late diagnosis. So I guess, and then of course we had the Autism in Pink project, which was a National Autistic Society project, an EU project, where we were looking at women in different countries. And of course there was a common theme, late diagnosis, and also lack of support in the longer term in terms of their future security. So yeah, and so since then it's become my special interest. The point is that the core difficulties between the males and the females are the same, but it's how the behaviours are manifested are different in the girls, and that's what is so important in getting the diagnosis right. So we look at what we call the triad of difficulties, social interaction being the most important probably, and so the girls usually present as more passive, and they mask their problems, they hide the problems, they watch and they imitate, and they appear not to be having the same difficulties as the boys. The boys are more obvious, more physical, and are clearer and easier to diagnose than the girls in terms of their social interaction. The girls really like to have friends, want peer relationships, and then are struggling. So that really is the essence of the difference in the social interaction. Then in communication, often the girls and boys are not that different in terms of verbal ability, though the girls tend to be more verbally articulate than the boys. But it's how they use their communication socially. So the girls don't actually use what we call chit-chat, social chit-chat. When they communicate, there's a purpose, and often it may be to do with their special interests, but despite that, they want to communicate. But it's really often on their own terms, rather than a truly reciprocal interest in another person. So that makes the difference between the boys and the girls. The girls are more socially communicative, but it's how they're communicating, the purpose of communicating, that is different from them. And then the third area is in imagination. And in the past, we thought that we took the very narrow view of autism, of a lack of imagination and creativity, which of course is not the case at all. I mean, everything that's happened over time, there's a progress, and it changes constantly. Our ideas change constantly. So the girls particularly have good imaginative play, more so than the boys, but they tend to escape into their own imaginary worlds. They, in terms of one person I saw recently, she zones out. So she's at secondary level, and when things become socially difficult for her, she then goes into her own world, her fantasy world. And she creates a whole series of different events that she can control and manage in a safe place. So the social creativity, social imagination is something that is really more evident in understanding the girls and knowing what their difficulties are. So the next area, of course, is the repetitive behaviours and routines. And in the classification systems currently, they are still male-dominated, male-stereotyped, trains, transport, cooling towers, whatever, object-related. But the girls' interests are more social interests. So they're interested in celebrities, soap. Animals are a favourite. Many of the girls we know really love animals. They may say that the animals are their friends because animals are less demanding socially, and they can love them unconditionally. So the interests are different in the boys and girls. So you do need to tease that out. And then somebody might argue, well, you know, what are these are interests of a typically developing teenager, celebrity soaps and TV stars, whatever. But in fact, it's not just what they do, it's how they are interested. The intensity and the quality of those interests is fundamentally different from a typically developing girl of the same age. So that's the area that I think we need to really concentrate on, is in the special interests. So those are the main things that reflect the differences between the boys and the girls. I think too, society expects girls to be more social. So in a way, it's a double barrier for them, in that they, particularly maybe in the workplace, they may well be in work in more male-oriented type jobs. And so perceptions of them as women as opposed to men make them find it more difficult. So in a way, the girls are a minority, autism being a minority within a minority. So they really do struggle in people understanding them and emotions. Another point too is their sensitivity. Another myth of people with autistic people lacking empathy is in the case of the girls, that is, I mean, I'm saying also in the boys, but particularly in the girls, they can be very sensitive to people's feelings, but they may not know what to do about it. So they'll know somebody's upset. They can read that in the facial expressions, but then they're not sure, well, what am I supposed to do with this? Because it's not coming instinctively. So one of the things that we say is that the girls lack social instinct. They learn the rules through their intellect rather than through social intuition. So you can imagine learning, constantly thinking about what people are saying to you, interacting with you, is a tremendous effort, which leaves them exhausted. It's not surprising then they need space. Particularly at the end of the day, if they've held themselves together in school all day, and then they get home, and then they can be themselves, and that's when it's necessary to say to them they need that space. Okay.